severe fetal morbidity of undiagnosed vasa previa, and they recommend routine screening with transvaginal color Doppler whenever low-lying placenta is seen in this woman. So we come to the donor pregnancies. Pregnancy from donor gametes, either it may be oocytes or the sperm or the embryo. They all have increased risk of gestational hypertension and preeclampsia. This compares to about 2% in controls versus 15% in donor. Significant risk. This risk is known to be seen in IUI conceptions also. If the lady is older, as in donor oocyte pregnancy sometimes, then the issues of advanced age also join in. We need to give low dose aspirin in this group and do the regular monitoring of the blood pressure. Donor oocyte pregnancy, during down screening, we need to calculate the risk taking into consideration the donor's age and not the recipient's age. That's one point we need to remember. Surrogate pregnancies, whenever a pregnancy involves surrogate, they have legal issues. ICMR guidelines that surrogate women, they are at risk for preeclampsia and placental abnormalities. So surveillance for hypertension is required here. We need to consider surrogates' wishes in clinical decisions in general, but there are some instances where commission couple have to be also involved. So we need to know that. Unforeseen and uncomplicated events may come up like congenital malformations, very preterm delivery, cesarean section, instances where the commissioning couple refuse to take the baby. All these may come up even though rarely, and we need to be aware of the management. So are there any risks with that? So outcomes of pregnancy after using surgically retrieved sperms, this is generally reassuring now, but the data is definitely limited. What studies have seen is even men with Klinefelter syndrome also can father normal babies without chromosomal abnormalities because the sperm is haploid. Recently, there was a series which reported where 100% of the babies born after Klinefelter syndrome, born from the Klinefelter syndrome father, they had normal karyotype. These pregnancies are usually uncomplicated and babies are healthy. And facing infertility themselves. And hypospadias, as I said, is another condition associated with offsprings of azoospermic men. Coming to PCOS. PCOS women have more incidence of OHSS, miscarriages, gestational diabetes, macrosomia, and stillbirth. They are usually obese and they also have these associated complications adding up with delivery. Metformin helps to reduce the incidence of OHSS in these women. Proper preconceptional counseling, maintaining HbA1c below 6.1% as recommended, tailored protocols for ovarian stimulation, deferring ART till adequate control of sugars is achieved. All this will help in management. Obviously, we need to screen them early for gestational diabetes. Preterm delivery, it's more common in multiple pregnancies, uterine anomalies, also iatrogenic prematurity when the woman has medical illnesses. ART per se has shown to increase the preterm birth delivery incidence in some studies. We need to consider, in that case, we need to consider corticosteroids for lung maturity. Magnesium sulfate helps for neuroprotection between 23 to 30 weeks. And there is a higher incidence of threshold of viability around 24 weeks. So because the pregnancies are precious, women want to try to salvage the baby at any cost. So we need to have a sensitive discussion of the poor survival, pros and cons of supporting these babies. So in this, we should consult the pediatric team and take a joint decision. Coming to age, nowadays there is a general trend of not so young mothers. With ART, advanced age is even more common. Even if the biopsied normal embryos are transferred in these women, second trimester screening as usual. Women over 35 years may have babies with chromosomal abnormalities. If we see more instances of miscarriages, low birth weight babies, placenta previa, diabetes, preeclampsia, and stillbirths, these incidents are increased in this group. We need to start aspirin before 12 weeks. Surveillance for medical illnesses, induction of labor at 39 weeks, this is advised. Cardiac and medical evaluation better done in the pre-conception period only. This is a widely quoted recent meta-analysis done by Maheshwari et al. This group showed that endometriosis and adenomyosis both have increased risk of what all miscarriages, preterm delivery, placenta previa, accreta, and PPH. As we can see in the slides where I have underlined, some of these risks are higher for ART conception and some are higher in natural. So you can see that even treated endometriosis affects the pregnancies. Also, the outcomes are different for different stages of endometriosis. If we compare adenomyosis, endometriosis overall, the treated endometriosis, early stage and late advanced stage, and the endometrioma and DIE, infiltrating endometriosis. Everything affects pregnancies differently. So outcomes are different for different stages. Commonly, we see the increased incidence of preterm, placenta previa, and accreta. With adenomyosis, the incidence of PPH is also high. So this is a summary from the same meta-analysis. We can see that cesarean section rate is high with all types of conception in these women. What is surprising observation is pregnancy-induced hypertension risk is more in natural conception. There is higher incidence of intrauterine death, neonatal admissions apart from the preterm delivery as we discussed. Babies' weight don't seem to be affected here. This meta-analysis included more than 100 studies, so we think it's quite comprehensive and reliable. So coming to the last trimester, in ART conceptions, there is no risk of stillbirth per se due to ART, but they may have preterm labor. So we need to do close monitoring for preterm labor to detect medical disorders, antepartum hemorrhage, and take a proper decision to induce labor as required in either hypertension, diabetes, or older mothers. So planned birth is always preferable. Timing of delivery has to be balanced. We need to avoid preterm or post dates. Malformations are there. There is placenta previa, fetal malformations, malpresentations, macrosomia, multiple pregnancy. Only then we need to consider elective cesarean. Labor management otherwise is routine. Still, there is some anxiety. There may be some additional interventions considering the sensitive nature. But we need to also take special care of those receiving heparin, and postnatal assessment for venous thromboembolism is required. Once the baby is born, admissions to NICU can happen sometimes, but there is no increase in the rise in the neonatal morbidity, especially school performance, adipose tissue development, testosterone levels in the long term, everything appear comparable to natural conceptions. So every obstetrician has the experience of caring for anxious patients. This is understandable. Women who had the difficult infertility journey, who conceived with prolonged treatment, they are all overly sensitive even to minor symptoms. These women need more reassurance. They request more interventions and admissions, even when we think that there is no clinical indication. In failed pregnancy or fetal, we need to be empathetic with these women and establish trust. And also they need more reassurance. So what happens to care providers? Doctors who care for ART conceptions, they work under high stress. There is a concern about minimizing adverse outcomes on the doctor's part also. This leads to more frequent monitoring, more admissions, scans, circlage, low cesarean section threshold. Family demands are also high and draining. There is this sword of litigation which hangs above every obstetrician these days. Counseling, maintaining. So With this, the patient will feel that the doctor understands them. This helps in avoiding miscommunication and problems in case untoward events happen. So, what we have seen in this short presentation, there are events in all the trimesters that can be influenced by assisted reproduction. What we need to do is be aware of the risk factors, keep up with the new data, mitigate the risk factors wherever possible. Example like starting aspirin, more closer surveillance as per the woman's medical condition, cerclage as indicated. We need to avoid post dates. Proper anomaly to them that ART pregnancies largely progress normally with proper monitoring. So with this, we can have a relaxed journey together. So even the more recent technologies such as in vitro maturation, embryo biopsy, assisted hatching, cryopreservation, none of these have shown to affect the embryos adversely. There are also no increased instances of fetal growth retardation, malformations, NICU admissions, perinatal mortality, or miscarriages, even when these latest technologies are used. Obviously, the data that we have is up to 5 years, or rarely in some cases up to adolescence. Longer studies and
Lavanya, any problem?
my presentation is done. If anyone has any questions, I can answer.
Okay. There's one question, ma'am. Is just want an enlight about use of vasodilator in early period.
Vasodilators like arginine, these sildenafil, these are used in frozen embryo transfer cycles. Blood circulation improves with this, and the pregnancy implantation will be better with these vasodilators. So once they are started, some practitioners they may stop after pregnancy is like established, and sometimes they stop immediately after conception, or sometimes they continue along throughout the first trimester and stop along with when they stop the luteal phase drug. So it is individual decision. When we come to evidence, there is no clear evidence that these help. All the evidence that we have for vasodilators is empirical.
We'll wait for next 2 to 3 minutes. I hope there are no questions. Yes, I hope there are no questions from your doctors. I have not got any response yet. Fine. Lavanya, can we end it?
Yeah. So thanks everyone. Thanks to all the doctors for participating. Hope this session was useful to you. Good afternoon.
Yes, ma'am. Thank you so much, doctors, for being a part of this webinar. Thanks for hearing. And thank you, Dr. Lavanya, for being on board for us. Thank you so much. Thank you so much.